All patients being evaluated for symptoms of COVID in any medical facility should be instructed to wear a surgical mask and perform hand hygiene. All patients should be placed on droplet and contact isolation, and all health personnel should wear the appropriate PPE, which is discussed in another module. While managing these patients, keep in mind the high-risk features for severe disease. Those include hypoxia less than 94, respiratory rate greater than 22, age greater than 50, and all of the comorbidities listed in the chart over here. In general, all patients should be initially managed with supplemental oxygen for respiratory distress and hypoxemia. Fluid should be used conservatively and only in patients with low blood pressure, dehydration, and shock. You should also consider the use of empiric antibiotic coverage in patients who aren't being tested for COVID that would cover typical community-acquired pneumonia pathogens and influenza. Further, the WHO and CDC recommend against the use of steroids in all patients with COVID-19 as it can prolong viral illness. Further treatment is based on disease severity. So let's go by each category. So patients with mild disease, remember these patients should not be tested unless they meet criteria for green zone, and any further clinical workup should be dictated regarding other clinical findings. They do not require admission and should be discharged. Patients should be treated at home with adequate isolation from others and be educated on signs of clinical deterioration. Remember, at any point in time, this is a spectrum, so patients who are mild can become moderate and severe, so they need to be informed on some warning signs and informed to go to the nearest hospital for treatment if these do occur. They should be instructed to wear a face mask when near other people, and any person participating in at-home care should wear a tightly fitting surgical mask when in the same room as the patient. These patients need to remain in isolation for up to 7 days after the first symptoms appeared, but preferably at least 3 days after complete recovery of the respiratory symptoms and their fever. If patients are classified as mild and were tested, then they should remain in isolation until they've had 2 subsequent negative tests, at least 24 hours apart. For the moderate category, these patients may or may not be tested, and they may or may not be admitted. The number one thing to decide about where you're treating them is actually an exertional hypoxia. So exertional hypoxia is measured while the patient walks in place briskly for 1 minute. An ability to walk in place, or if oxygen saturation falls below 90%, it's considered test failure and requires admission to an appropriate level of care. Your other general management is going to be with oxygen, fluids as needed, and empiric antibiotics based on chest x-ray findings. You can use Tylenol for fever management. And remember, if this patient does require admission and has not previously been tested, this patient is now in the green zone and requires COVID testing. Patients who pass exertional saturation testing can be discharged home and told to follow up outpatient in 24 to 48 hours. They should receive the same education for home care as patients with mild disease, as they can also progress to severe disease at any point in time. Patients with severe disease require inpatient hospitalization. They're going to require isolation, appropriate PPE for all healthcare workers, and the goal in treatment of these patients is to provide adequate respiratory support through supplemental fluids and oxygen or non-invasive positive pressure ventilation until the patients recover. If the patient has ARDS, they're going to require intubation with mechanical ventilation in the ICU, and further management on ARDS is discussed in a separate module. So just a little correlate. There are several drugs that have been hypothesized to help, but there's no control data supporting the use of any of these. So if you want to learn more about them, I encourage you to seek further information on your own. And last thing that I want to talk about is symptom resolution. So remember, we touched on it briefly in the second module, but once a patient becomes symptomatic for mild disease, it can take up to 2 weeks for that to finally go away. And for severe disease, it can take anywhere between 3 to 6 weeks. So patients should be educated that they shouldn't come back if they're not getting better. They should come back if they're getting worse, but that it can take a significant amount of time for complete disease resolution.